I'm Sylvia, and I love the chance to talk to you about the topic of patient-driven science. So how patients and patient organization can drive breakthrough in clinical development, and what has been my experience over the last few years working at Through Vicky's Eyes. So first of all, who are we? So we're a very small volunteer-based organization that is looking at funding research against like Leber congenital amaurosis, LCA, linked to gene RDH12. This is actually a rare or ultra rare inherited condition that is affecting children and leading them to blindness. Actually, I'm also the mother of a child affected by this disease, Vicky, who you see in the middle of the picture with the red dress. So that's my 8-year-old Vicky. And so we are really working hard to help Vicky and kids like her see the world for longer. There is currently no treatment for this condition, but we're working we hope we can get into a clinical trial very soon as a result of the work we're doing. So really, how can patients drive breakthrough in clinical development? I'm going to touch into some highlights of my own experience. First of all, giving access to patients. I mean, it's something that we do, and it's great advantage and value for researchers and clinicians. We also, of course, can give grants and funding, but I want to spend more time on talking about how we can be the catalyst for collaboration and innovation among the research community. So really on the access to patients, one of the first things we did is actually creating an organization. I'm sure you've done the same in your own fields, but we now have over 100 families, which doesn't sound like a lot, but for an ultra rare condition like ours, it's a great achievement. We have people from all over the world, and we really also use it to show everybody working in the research environment that, you know, there is people out there that are interested in their work and really showing a potential for that. As many of you probably have done, we're also very active in the grants funding front, so giving financial support and to a number of institutions and really seeding science all over the world. Just recently, we published our new research strategy. We're very focused on a few things, big buckets, and of course that's something that it's critical. But most of all, I want to spend more time on really how can be the catalyst of collaboration. We heard a lot about collaboration even in the earlier sessions this morning, and here are a couple of examples of what we have done, and hopefully it can be an inspiration for you. One of the first things we did is actually publishing and creating what we call like a scientific landscape on Vicky's on our condition. And this was done in partnership with an external research partner, but really looking across all everything that has been published, talking with all the stakeholders, and really publishing what is the state of the art on the condition. And you might think that researchers already have all the answers and already know all of it. I can't tell you how many good feedback I had from leading researchers around the world telling me, hey, I've never seen it all combined in one place and I learned something new. This ended up actually being published in a peer-reviewed article, one of the largest and most important journals in ophthalmology. So, so somebody like me that doesn't come with any background in research, having a peer-reviewed article under my name felt like a great thing. But I can definitely recommend something like this, especially if you're starting from the beginning on your research journey. That actually enabled us to go to the next breakthrough, which has been actually driving the very first scientific workshop. So bringing together scientists, organizations, biotechs, even the FDA, to actually discuss where to go and what are the biggest opportunities for our condition. And so that's something that we have done with great success. We're also working on a couple of new things, so more to come, again, in the area of breaking the silos and fostering collaborations, international collaboration, where I think really us as patient organization are very well suited, you know, break some of those barriers and working through making sure people collaborate more effectively across the globe. So really here my lessons learned, focus on identifying the research gaps and opportunities, develop a roadmap, advocate, be the catalyst, and really think about the role that you can do to drive science. We can actually do much more than what we think we can. So here are my contacts, and I think with that, I'm close to 5 minutes. Thank you.
Hi, everyone. I'm super excited to be sharing some findings from my master's dissertation on barriers and facilitators to diagnosis for rare diseases. So the diagnostic pathway can be long and complicated for many rare disease patients, and an average rare disease patient will consult 5 different doctors, wait 4 years to receive a diagnosis, and receive 3 misdiagnoses before receiving an accurate one. So it's important for patients to receive a timely and accurate diagnosis, as it allows them to access appropriate treatment and services. And delays in diagnosis can negatively affect their health, finances, and work or school. And so in order to reach a diagnosis faster, we need to better understand what factors affect time to diagnosis. So that was the main question for my review. What are the barriers and facilitators to diagnosis for rare diseases? And to answer this question, I conducted a systematic review analyzing 27 studies, including quantitative, qualitative, and mixed method studies. And we examined either rare disease patients, their families, or healthcare providers. So what did we find? Well, the barriers and facilitators to diagnosis were organized into 4 main categories. So one being disease factors, for example, characteristic symptoms of a disease. 2 was patient and family factors, so things like sociodemographic factors. 3 was healthcare provider factors, for example, rare disease knowledge. And 4 was systemic factors. So these were defined as those related to the healthcare system, including things like testing resources and workforce training. And further sub-themes were developed and organized into these 4 categories. But in the interest of time, I'd like to explore just the main, most frequently mentioned factors. So the major barriers to diagnosis included having nonspecific or mild symptoms, and also being of older patient age. So older patients felt that the clinicians were more focused on treating their symptoms rather than finding the root cause. Another barrier was in accessing the appropriate specialist care due to lack of referrals or things like lack of trained specialists. Final barrier was limited availability of diagnostic testing resources, such as testing laboratories and interpreters. The major facilitators included earlier manifestation or more severe symptoms, also receiving an appropriate specialist referral, delayed diagnosis, and access to multidisciplinary specialist centers helped improve the continuity of care and improve the communication between the healthcare provider team. And finally, attending postgraduate continuing education training for rare diseases was also a facilitator. So now that we've identified some major influential factors here, where do we go from here? Well, perhaps addressing the systemic factors could have the greatest potential to improve diagnosis. For example, improving education and training for healthcare providers could lead to an increase in the number of trained test interpreters and therefore increase capacity for diagnostic testing. More training could also improve clinician knowledge of diagnostic indicators, which could facilitate earlier suspicions of a rare disease diagnosis. Better training could also improve referral rates by increasing clinician understanding of when and where to refer patients to. And more referrals to specialist care and more trained specialists could speed up diagnosis, as that was one of the main facilitators to diagnosis. And so this example is just to show the potential downstream improvements to diagnosis that could result from addressing systemic factors. So in summary, barriers at the disease, patient and family, healthcare provider, and systemic levels contribute to delays in diagnosis. Investment across all health sectors is crucial for improving rare disease diagnosis. And based on these findings, some recommendations for reaching a diagnosis faster include increasing postgraduate training, especially among primary healthcare providers, improving access to specialist care so patients can see the right specialist faster, and lastly, increasing testing capacity so more patients can access diagnostic testing and receive timely results. And I'd also like to give a huge thank you to my supervisors and collaborators, Drs. Holly Walton, Angus Ramsey, Amy Hunter, and Jennifer Jones for all their help and support on this project. That concludes my presentation.
Lucy Mackay. I'm usually known as the CEO of Medics for Rare Diseases, and I did represent Medics for Rare Diseases while I was doing Ardent, but today I'm here to talk to you about Ardent very briefly. Ardent stands for Action for Rare Disease Empowerment. It was a group that was brought together in early 2020. If you cast your minds back to then, we didn't know what we know now. And this group was formed in April, originally called Avengers Assemble, but the name didn't catch on. And eventually, we went on to publish a report called Rare Disease and the Lessons Learned from the COVID-19 Pandemic. And I want to talk to you about next steps and basically make a plea for everyone to get involved. I can't thank everyone because I'll lose the game. But here are some of the groups that were involved, and there were many more individuals. Please do go to the actual report so that everyone gets thanked. We came together as like a multiple stakeholder group, cross sectors. That was so important about this because there were people in silos doing this over there because of the pandemic and this over here. And it was really important. We all came together to examine how the fragile rare disease infrastructure and ecosystem was being affected by the pandemic in early 2020. We had discussions amongst the different stakeholders. So people living with rare diseases, family members, advocates, doctors, researchers. Remember, you can have multiple identities. And we came up with 3 themes that we thought where risk was high to the rare disease ecosystem. 1 was diagnostic delay. 2, health and social care coordination. 3, research, drug development, and access to treatment. We split everybody into these 3 groups. Some people spanned all of them. Some people were just on one. And then we went about with our aim. We wanted to shed light upon the unseen impacts of the pandemic on people living with rare conditions in order to protect their existing services and to harness opportunities for the future. This wasn't all about negatives. We were seeing exciting things come up, telemedicine, but making sure these things are harnessed appropriately. This is how we did it. We captured evidence. Lots of it wasn't peer reviewed and still isn't peer reviewed because it was only just happening. But there was some published research that came out, articles, blogs, survey results, reports, surveys. Oh, I said survey results, self-published reports. We had some great students from Keele who came and helped each section, collated the evidence, looked into going into government databases and finding the data that is available, but you can't read it. We did interview from experts all over the community, and we created 3 theme reports. We then put them together to create the theme report, the final report I mentioned, and we're using this to help influence policy and to keep this diverse group of voices together and making sure everything's going on the right track. You'll notice that we decided our 3 priorities well before the Department of Health in the UK decided their 4 priorities. So we jumped the gun. First theme, the finding was the pandemic has exacerbated diagnostic delay. I don't have enough time to go into each of these findings, but that's okay because there's a 4-part webinar series coming up starting tonight. If you want to know how we found this finding, then you just need to turn up tonight, 6:30 online, Royal Society of Medicine, and Joe, my lovely colleague, is going to put all the details in the chat. I'll just give you some brief ideas. What we saw is discrete number of diagnoses going down reported by things like specialist nurses. With what little data is collected regularly on rare disease, we found some conditions where we could be quite sure that the numbers of rates of diagnosis were going down. We also found this with new families signing up to patient groups. They were going down. Referrals were going down. Important tests that are regularly used in rare diseases plummeting. And so those are some of the reasons we came up with this, but find out more later. Theme 2 found that the pandemic has compounded existing inadequacies in what you can't see, but does say health and social care coordination. I don't think this can come as a surprise to anyone. A lot of this is based on data of patient groups who've done amazing survey reports and also from expert interviews, etc. That's next Tuesday. Sign up for that one. The Tuesday after will be about theme 3. The pandemic has exposed the fragility of rare disease drug development. I mean, I've got to stop. Okay, I failed. Quick, right.
Your own timer stopped before mine. You had a second more on my clock, Lucy. Please finish your sentence and then we will wrap up.
It's going to be a long one. Read the report, attend the 4 sessions to find out the details. And this is the most important thing. Please come and join Ardent if you want to be involved in this kind of work. It's informal, it's open, we're friendly, join us. This is the webinar series. And this is the information of each of the theme leaders. If you're not sure, just message me on the platform Swapcard. Thank you, Beacon.
Good afternoon, everyone. My name is Elisa Ferrer-Mallol. I'm Patient Advocacy Manager at Apparito. Apparito is a medical technology company specialized in capturing patient-generated data and digital endpoints remotely. So in the next 5 minutes, I'm gonna speak about patient-driven innovation. We all know products that have come to the market with huge expectations, great hype, but that have failed to deliver because no one really knew what they were about and what they were for and how to use them. In the context of rare disease drug development, the same happens if patient needs are not taken into account. In this slide, I just put a couple of examples, like the use of the 6-minute walk test in Duchenne muscular dystrophy as primary endpoint in drug efficacy clinical trials, which excludes patients who are no longer able to work. And it not only excludes them from the trial, but also from any potential therapies derived from it. In another example, in idiopathic pulmonary fibrosis, the main endpoint is an objective measure of lung capacity that, while it's very important, it fails to capture other symptoms more relevant to patients like fatigue. In general, there's a lack of rare disease-specific patient-relevant outcome measures, and therefore, since they are not available, they are not used in clinical trials. And we borrow other outcome measures from other disease areas, and this leads to suboptimal results. Often patient needs are not taken into account because of the conflicting priorities between the patient community and other stakeholders when it comes to research. Patient-driven innovation can take many shapes, from patients directly acting as innovators and developing their own solutions, to more structured and systematic forms of patient engagement with different stakeholders and at different stages of the product life cycle. But in any shape or form, patient-led innovation addresses the unmet needs of patients, carers, and families. It is more inclusive because it considers all the disease stages and all the subtypes of a given disease, and therefore targets a broader patient population. And it leads to more relevant and efficient therapies and less clinical trial waste. It also leads to improved patient access to therapies. But there are also barriers, like the lack of resources that don't allow to patients to start their own research, and the engagement with relevant stakeholders that might not occur as early enough in the process as desired. At Apparito, we take a co-creation approach to try to overcome those barriers. Since the beginning, Apparito has partnered with rare disease patient groups to try to address through digital health technology the challenges faced by patients and families, like the lack of meaningful outcome measures. In 2020, Apparito launched the Patient Group Accelerator program to foster the development of patient-led solutions and to use the technology to bring the patient's voice into clinical trials. The Patient Group Accelerator program is a 6-month program that it starts with an assessment of the needs of the patient community and the context of use of the potential solution. Then we select the outcomes of interest and we start the development of the technology, which it will be later tested in a small group of patients. We gather the data, we analyze it, and at the end of the program, we have an idea of the feasibility, acceptance, and usability of the technology. We also have gathered exploratory data to support the clinical utility of the technology, and we have started the groundwork for future qualification of the technology and its use in clinical trials and clinical care. As you see here on the screen, Duchenne UK and PCD support group were the first 2 patient groups that joined our first round of the Accelerator program, and with whom we continue to engage. And if you want to know more, please check our website and let us know if you have any other questions. Thank you very much.
Hi, my name is Ingrid Westerheim, and I'm the president of Osteogenesis Imperfecta Federation Europe, called OIFE. Thank you so much for inviting me. Next slide, please. Most people who have heard about OI connect it with brittle bones and fractures, but OI is a rare genetic collagen condition affecting all organs of the body containing collagen, and variation between individuals is huge, which is why we need big data. Next. So IMPACT is a joint initiative between OIFE, the American OI Foundation, and the company Mareo Biopharma. The idea came from Mareo, who paid for the project, but the organizations took ownership because we saw the huge need for more data to fill the knowledge gaps. The survey was developed based on a literature review and was open from July to end of September 2021 in 8 languages. Next. But it wasn't enough that we as an umbrella organization saw the benefit. We needed everyone in the community to be aware, support, and feel ownership. Next. And thanks to the impressive help of the entire global OI community, we managed to get more than 2,200 unique responses from people with OI and parents from more than 65 countries. Next. Our aim was to learn more about patient journeys, care pathways, quality of life, and economic impact, also called burden of disease, which we deliberately avoided to call it. Our members certainly didn't want to be labeled as a burden to society. Next. We established the project in April 2020, and it was first mentioned to our organizations in June 2020. We repeated the message several times before we launched. And between July and September 21, we communicated, analyzed weekly reports, and talked about impact in membership meetings before we closed the survey on September 30th. Next. The company developed a comms package, but we quickly realized we had to make it our own. Next. We developed some key messages and a hashtag. We had a landing page before the survey was launched, and a web page with an easy to remember short link to explain about the project. Next. We created banners for social media and a frame for those who had taken the survey. We also introduced an element of competition. A couple of times per month, we posted a country stats, tagged the organizations, and praised countries who did well since last time. Next. Our weekly reports also included type of respondents, and we quickly saw the need to create communications towards certain target groups, men, as usual, and healthy parents. Next. So what were the success criteria? Time. We started talking about the project 1 year before the launch. Relevance. We had large influence on the questions and translations, which made the survey relevant for the community. Trust. We stressed that the data would be owned by the organizations. Motivation. We explained what's in it for you and launched national reports as carrots. Next one. We took ownership as a global community. We did not promote any other surveys or competing projects in this period because survey fatigue is real. And based on our weekly reports, we nagged, motivated, and pushed organizations, target groups, and our Facebook friends. It's a miracle I still have some left. Next one. So, did we learn some lessons? Of course we did. Summer holiday season, it's not an ideal time to launch. Language barriers are real, but having many languages is also a lot of work because translations must be checked, and this takes much more time than you think. Don't make it too long, the survey, but if you do, make sure to include submit buttons for each chapter then you can use the partial data anyway. Don't be naive. Informing is not enough. You need to check that the messages are received, understood, and that people are ready to act. Competition works, and weekly reports and personal follow-up are essential. Next, which is my thank you slide, and questions are welcome.
Well, thank you very much for the opportunity to be here today. It's a pleasure to speak to you all. I work for Pfizer in the UK in market access for rare disease. And yeah, I'll be talking about patient centricity in rare disease market access. So I'm going to cover off 3 separate projects that we're currently working on across our portfolio. And in the UK, we tend to work on new treatments in our pipeline around about the point of the pivotal trial, around about the start of phase 3. So what we're talking about is things that we're doing in addition to phase 3 trials, in addition to pivotal trials, and implementing patient-centric projects to support patient access, with the intention of bringing that reimbursed patient access as early as possible to the point of marketing authorization, so patients in the UK can benefit from breakthroughs as quickly as possible. And these projects are based on key insights that we've gained through our interactions. So first of all, appraisals of new medicines don't always include an assessment of the impact of the condition on carers as well as patients. And that's led us to our carer burden study. Secondly, for certain conditions, a lot of conditions, we know that patients and clinicians will work together to determine whether a treatment with a gene therapy, for example, is the right choice. And that's led us to our patient preference study. And then thirdly, innovative treatments like one-time gene therapies may have quote unquote small clinical trial data sets with the possibility of long-term benefits and potentially a high price per dose. And that can lead to uncertainty and affordability concerns in the eyes of payers. So first of all, looking at the carer burden study. So we've worked with and are working with patient advocacy organisations in 2 different avenues for this one. It's looking at the experience of unpaid caregivers of people living with a rare disease in the UK. Both of them are designed to inform our interactions with the health technology assessment bodies, so NICE and SMC in this case. And by doing this study in 2 different ways, we can present the outcomes in a way that carries the weight that the HTA bodies will need. So first of all, looking at the carers themselves and the impact of caring on their health-related quality of life. And then secondly, looking at this through the dimension of members of the general public to get an assessment of how they would perceive the impact on their health-related quality of life. And by combining those 2 things, we can present it in a way that hopefully NICE and SMC, et cetera, and other HTA bodies would respond well to. The second one is looking at patient preferences. So this is examining the preferences of people with rare diseases for potential new treatments. And again, we've worked closely with patient advocacy groups, HCPs, and expert patients in the qualitative phase to identify the treatment attributes to investigate. And then that has supported us to design the quantitative phase, but also test it for health literacy, which is a very important thing, I think, particularly in this context, because a patient preference study can be quite technical. We need to make sure it's presented in a way that resonates with the people whose input we're looking for. And then this quantitative phase is then something that's a discrete choice experiment, which is a mechanism for patient preference that should produce a statistically robust outcome, answered by people with this specific condition via an online platform, where they judge the relative importance and value of treatments across different attributes. And then the outputs of that, the results, have the potential to support regulatory benefit risk analysis, the potential to support the health technology appraisal decision-making, and also potentially inform our understanding of the informed consent discussions between patients and physicians. And then moving on to the third one, which we've termed Project Genesis. And this is our pilot project to develop a gene therapy reimbursement model that links value to outcomes, which is important to address those challenges of affordability and uncertainty. And again, here we're working in partnership with patient advocates and expert clinicians to develop this model. And it's divided into 4 sections. So first of all, starting with the outcomes, what are the outcomes of treatment that are important to the patients, to carers, and to clinicians? When we've determined what those are, then it's looking at the data infrastructure and how we can develop or build platforms to collect and manage these outcomes with a minimal admin burden on patients, clinicians, and any other frontline medical staff. That then leads us to develop a contract structure that links the value of the treatment to those outcomes. And then finally, we model it, we see how it can work in the real world, linking it back all the time to what's important to the people that this treatment is designed to benefit. So those are our 3 projects. And just in closing, I'd say that leading with an intent to be patient-centric has increased the dimension of innovation in our work. And each interaction with patients, caregivers, and patient advocates has led to a critical insight that helps shape our work far beyond that specific project. Thank you. Any questions?
Hello, everyone. My name's Samantha, and I'm a junior doctor as well as a patient living with the consequences of a rare disease. This was initially misdiagnosed due to doctors missing the red flag signs and symptoms. And I'll offer some insights into working with young people and those with rare disease. So I grew up in South Africa, and one day when I was 11, I suddenly woke up with severe back and leg pain. I developed numbness in my lower body and constant pins and needles in my feet. My mum repeatedly took me to the GP, who misdiagnosed rheumatic fever, growing pains, and juvenile arthritis. And despite rapidly deteriorating and now also experiencing difficulties walking and going to the toilet, I was not asked any direct questions as to whether I was having any other symptoms, nor did I have a full examination of my nervous system. A consultant also failed to perform a neurological examination and told my parents I was attention seeking. A whole month later, I could hardly walk, and I was finally referred to for an emergency MRI scan of my spine that revealed a likely spinal cord tumor. But I needed further tests to rule out something exceptionally rare. These tests revealed a spinal cord arteriovenous malformation, or AVM. By this stage, I was completely bedridden. My pediatric neurosurgeon saw only one case like mine every 5 years, therefore didn't feel he had the experience to successfully operate. And the world expert in spinal AVMs was in New York, and he agreed to attempt the surgery. However, he did warn my parents it was unlikely I would ever walk again. 4 months after my initial symptoms, I had an 11-hour operation to remove the AVM, and a year later, I was able to walk independently. The life-changing impact of my experiences made me determined to want to become a doctor myself one day. So a spinal AVM is an abnormal tangle of blood vessels in or around the spinal cord. It is congenital, however, only usually discovered later, either due to symptoms related to reduced blood supply, a bleed, or in my case, spinal cord compression. If the red flag signs and symptoms for this are missed, it can result in permanent neurological damage and even paralysis. Spinal AVMs are exceptionally rare, particularly in children, and there's therefore very little information in the medical literature about their incidence and prevalence. It is estimated that my type of spinal AVM affects fewer than 1 in 1 million people. At medical school, I was shocked to learn about the red flags for spinal cord compression: worsening back pain and weakness and pain in both legs, bladder and bowel dysfunction, loss of sensation, and abnormal reflexes. We were taught how absolutely crucial it was to not miss these due to the potential irreversibility of the consequences. For me, the delay in diagnosis resulted in permanent loss of sensation, neuropathic pain, poor balance, abnormal gait, and leg weakness, as well as foot muscle paralysis, leading to deformities requiring 3 foot reconstructions. I have a neurogenic bladder and bowel requiring self-catheterization, regular bladder Botox injections, and a colostomy. And as well as having a psychological impact, my career progression has also been affected due to all the time I've needed off work for multiple further operations. So why were the red flags missed? In South Africa, a doctor can become a GP straight after internship, whereas in the UK, a 3-year specialty training program is required. My GP didn't have to seem to have the red flags on his radar, so didn't ask appropriate direct questions or examine me fully. It is so important to invest time in building a good rapport with pediatric patients. I didn't volunteer the information about my symptoms as I was shy and embarrassed, and I didn't even realize it was relevant. However, the consultant also missed the red flags. and I wonder whether there was an element of medical negligence. So some tips for working with patients with rare disease. Remember, the patient may not be a textbook case. Always seek advice early. Be honest about your understandable lack of knowledge due to the rarity of the patient's condition, and encourage a patient who's an expert by experience to educate you on their rare disease. Always think rare. Thank you.
Well, good afternoon. My name is Susan Alves, and together with Catarina Gavalho Gomes, we will present this work to you. We will start by presenting a situation. When a family is faced with a CDG diagnosis, like for example, PMM2-CDG, they are often very confused and ask many questions. What is PMM2-CDG? Well, congenital disorders of glycosylation are a group of rare metabolic and genetic diseases. PMM2-CDG is one of them. Actually, is the most recognized form of CDG. Does it have a treatment? Currently, there is no specific treatment for PMM2-CDG. The only therapeutic options are preventive and directed to the specific symptoms presented by each individual. But it is possible to learn about specific symptomatic management for PMM2-CDG thanks to the international clinical guidelines for the management of PMM2-CDG diagnosis, treatment, and follow-up. But there's a big problem. Let's put ourselves in the CDG family shoes. We gave these PMM2-CDG guidelines for families to read and to tell us what they couldn't understand. And guess what? Here in yellow, you can see what one of our families said that they couldn't understand. This is just in one page. So knowing that this document has 24 pages, at the end, there will be too many words that these families couldn't understand. In sum, the medical and scientific jargon prevents families from benefiting this great resource. This is the part where we make your day. We are creating the solution. The solution is to create readable and understandable resources for people living with PMM2-CDG, their family members and doctors, based on the international clinical guidelines that we just saw. How, you ask? Well, this journey started in January 2021 and is still ongoing. As you can see, we set up a task force, citizen board, and family board, who helped us by reading, highlighting those words difficult to understand, and gave us ideas on how to make these guidelines in a lay-friendly format. A major conclusion was that we were advised to create 6 types of resources.
The results are a document entitled Understanding and Coping with PMM2-CDG, a guide for patients and their families, which is being carefully made to be easy to understand and read. It is through this main document that the other 5 resources will be born. Through the process of creation, we are facing a lot of challenges, and note that we now have to work based on the feedback we collected. The most frequent suggestions focus on friendly language, clear exposure of ideas, and an organization prioritizing the most frequent signs and symptoms. And how to overcome these challenges. We created a methodology where we put together a series of simple language writing rules and patient-friendly tools as examples for our work. We are also applying visual tools and standardizing the structure to facilitate and speed up the visit to the document. How do these tools really benefit the CDG community? Well, with these resources available, we hope to contribute to an improvement in diagnosis, management, and a boost in clinical development. These documents are a way of standardizing care in all countries and making patients and family members more informed and empowered to make decisions. On these 6 resources, you have a place with relevant information and in an easy language that tells you what to do regarding the management of specific signs or symptoms. Stay tuned, soon all these resources will be on the web platform, and for more information, visit our site or our Facebook page with the links below. We are collaborators from the CDG and Elias, and also students at the Nova School of Science and Technology. And we are deeply grateful to all partners for their support of this work conducted via CDG and Alliance BPAIN in the scope of our educational and raising awareness activities. Thank you all.
So I'm a hematologist by trade, and I'm at Oxford, and I have a keen interest on looking after people with Castleman. So what is Castleman's disease? It's a very rare lymphoproliferative condition, which basically means there are lymph cells in our body that can divide more faster. We still don't understand why this happens. There is clearly a driver. There's a lot of research, and this can affect all age groups, but mostly of people in the 4th to 5th decade of life. Slightly more common in men, and we estimate between 6,500 to 7,700 new cases of Castleman disease in the US, who seems to have a more robust way of collecting this data, and therefore the estimates in the UK is between 1,300 to 1,500. There is a cohort of people with Castleman disease who have multi-location lymph proliferation called multicentric Castleman disease, and this renders people to be clinically more unwell. One of the challenges with Castleman's disease presentation is that clinical symptoms and the clinical signs can mimic a number of different healthcare conditions. So a person could present with flu-like symptoms, with night sweats, it can be anemic, could have kidney dysfunction on a blood test, could have a skin rash, can develop swelling in certain areas, can present with breathing issues or raised lymph glands and splenomegaly. So people could start thinking about an autoimmune disorder. People could be thinking of an infection, or people could even be thinking of some type of malignancy. So this is a big challenge that we have. Apart from the rarity of the condition, we have disease mimics, which stops us from diagnosing these patients early or put them through the right clinical pathway from primary care into secondary care, or be stuck in different clinics in secondary care, not getting to folks like us who can diagnose and treat them. So one area we've focused on is about diagnosing people better, because one of the concerns has been is misdiagnosis, and therefore we've now jointed that into our cancer diagnostic pathway, although this is not technically cancer, and we're using the specialist integrated hematology malignancy diagnostic service to diagnose people better with a pathologist, hematologist, and radiologist. And there are existing centers around the country, and they're now being guided to diagnose Castleman disease. But we haven't stopped there. We have additional pieces of work that we are carrying out to improve the outcomes for Castleman disease. The first is data. We have an accelerated routine care database that we're putting data in to understand natural history, build a data source for collaboration, and collect real-world data of how people do with this and the treatments. Second, we are educating people on Castleman's disease. There is an international effort, and there's also local effort in the UK, and I've led the piece of work with British Society of Hematology around what is good practice for the management of Castleman disease. It got published a couple of months back, and we're going to showcase that in our British Society of Hematology meeting in April. So this gives people a document to anchor how they manage people. Third is in the UK, we've developed a specialist UK Castleman disease advisory service. And this is particularly because we've identified in our clinical care that patients are delayed or incorrectly diagnosed. And therefore, we want to have a national advisory service which will provide advice, which will provide a diagnosis and expert pathology service, as well as robust management advice. And we want to capture this clinical data. French have done this slightly differently. They've got a national reference center grouping all the key individuals who need to be there to diagnose patients better, and also integrate in the form of research projects and developing a patient registry, and also helping patients find an expert. So this being a very rare condition and challenging because it mimics a lot of other disorders, and we are taking this multi-pronged approach to try and improve the outcomes for patients with Castleman's disease. Thank you.